Good evening, students. Today's class is on plasma protein. In today's class, we are going to learn what are the different types of protein present in the blood and what are the function of each of this protein and what is the clinical significance related to each of this protein. So before going to the today's topic, first we will see what is the difference between plasma and serum. Then we will learn what are the proteins which is present in the plasma. So coming to plasma versus serum. So when you collect venous sample from a patient, that sample is called as whole blood. So the whole blood consists of RBC, WBC, platelet and the fluid component. So if I remove all the cellular component, the remaining fluid component including uh, clotting factor is called as plasma. So plasma is nothing but whole blood minus cellular component. So if I remove the cellular component from the whole blood, the remaining fluid is called as plasma. Plasma contain clotting factor. And if you remove the clotting factor from plasma, I'm going to call it as serum. So serum is nothing but plasma minus clotting factor. So we are going to see about the proteins which is present in the plasma. But remember, sometimes we have to measure the protein in serum rather than plasma. Okay, so whether it is total plasma protein or serum albumin, everything we are going to speak about the protein present in the blood. Types of protein. So based on the mobility in the electric field in electrophoresis, we can able to separate the protein into different types. So the protein which is present in the blood can be subdivided into different types based on their mobility in the electric field in electrophoresis. In the next class, I will teach you about what is mean by electrophoresis and how we can able to separate different types of protein present in the blood using electrophoresis. Okay, for today's class, remember, based on their mobility in electric field in electrophoresis, we can able to divide the protein which is present in the blood into different types. So there are totally three types. First one is albumin, second is globulin, third is fibrinogen. Okay, so this albumin is a single protein. The fibrinogen is a single protein, but globulin is not a single protein. It's a group of protein. Okay, so this group of protein is subdivided into four subtypes. So what are those four subtypes? Alpha 1 globulin, alpha 2 globulin, beta globulin and gamma globulin. And remember, even this is not a single protein. That is alpha 1 globulin made up of multiple proteins. And alpha 2 region we have multiple protein. In beta region we have multiple protein, and in gamma, under gamma we have multiple protein. Okay, so this is not a single protein. Okay, so this globulin, a group of globulin protein is further separated into group of subgroups, that alpha 1 globulin, alpha 2 globulin, beta globulin and gamma globulin. Next we'll see about the importance reference value related to the plasma protein. Then we'll see in detail about each of this protein. So coming to the reference value. So the important reference value which you need to know is, first one is total protein. Second is serum albumin. Third is globulin. Fourth is albumin globulin ratio. AG ratio means albumin globulin ratio. Okay, so you have to remember only this four values, reference value related to plasma protein. So what are those four values? Total protein, albumin, globulin, AG ratio. So what is the reference value for total protein which is present in the blood? It's 6 to 8 gram per deciliter. Okay, 6 to 8 gram per deciliter. For albumin, the reference value is 3.5 to 5 gram per deciliter. And for globulin, the reference value is 2.5 to 3.5 gram per deciliter. Okay, and the AG ratio, albumin globulin ratio is 1.2 is to 1 to 1.5 to 1. Okay, so this is the reference value for this four parameter, and you have to remember only this four parameter. So we have seen about the types of protein and the reference value for important proteins. Next we are going to see about each of this protein in detail. So we'll start with the albumin. So first point related to albumin. Albumin is the major protein which is present in the blood. That is, it constitutes about 50% of the total protein present in the blood. Okay, so the first point is it is a major constituent of plasma protein. Second point, it is produced from liver. Okay, albumin is synthesized from liver. Okay, third point, the size of the albumin is 69 kilodalton. Okay, it's important when we teach you about nephrotic syndrome, you will come to know the importance of knowing this molecular size. Okay, so the albumin has a molecular weight of 69 kilodalton. Okay, it has molecular weight of 69 kilodalton. Okay, and in the previous slide I had told you the reference value. What is the reference value? 3.5 to 5 gram per deciliter. Okay, 3.5 to 5 gram per deciliter, and albumin has a half life of 20 to 25 days. Okay, so what does it means? That is, once the albumin is produced from liver, it will circulate in the blood for next 20 to 25 days. Okay, so the importance of this point also you will come to know in liver function test. Okay, albumin has four important functions. So what are those functions? The first function is it is going to maintain the oncotic pressure in the blood. Okay, it is going to maintain the oncotic pressure in the blood. Okay, second important function is it is going to act as a transporter. Okay, it is going to act as a transporter in blood. Okay, third important function is it is going to act as a very good buffer in blood. Okay, and fourth important function is it has nutritional function. Okay, so these are the four important functions. We are going to see little bit in detail about each of this function. Okay, so we'll start with the oncotic pressure. So what is mean by oncotic pressure? So in the previous class I have told you something about osmotically active particle. So what is an osmotically active particle? These are the particles which can able to attract water towards themselves. For example, glucose, sodium. So these are osmotically active particle. So how they are going to attract the water towards themselves? By using osmotic pressure. Okay, so what is mean by oncotic pressure? Oncotic pressure is a type of osmotic pressure. It is a type of osmotic pressure induced by albumin in the blood vessel. Okay, so now you are having albumin in the blood vessel. Okay, and they are inducing osmotic pressure. Okay, that is oncotic pressure. Okay, so they are going to attract water towards themselves. That is, they are going to mobilize the water from the tissue into the blood vessel, because albumin is present in the blood vessel. So it is going to attract water from the tissue into the blood vessel. Okay, so oncotic pressure retain the water in the blood within the blood vessel. Okay, so it is going to retain the water within the blood vessel. Okay, uh, so oncotic pressure at arterial and venous end of the capillary is same, that is 25 mmHg. Okay, so what we had learned, what is mean by oncotic pressure? Oncotic pressure is a pressure which is going to mobilize the water from the tissue into the blood vessel. Okay, and this oncotic pressure is induced by albumin. Okay, so why we have to know about oncotic pressure? Because using this mechanism only, our tissue is going to get nutrition. That is, from the artery, water and nutrition will be mobilized to the tissue, and from the tissue, waste products and the water will be mobilized to the venous. Okay, vein. Okay, so to understand this concept, you should also know about hydrostatic pressure. Okay, so what is mean by hydrostatic pressure? It is the exact opposite of oncotic pressure. Okay, in oncotic pressure, I have told you it is a pressure which is induced by albumin, which is going to mobilize the water from the tissue into the blood vessel. Okay, it is attracting water into the blood. Okay, so it is the opposite. That is, hydrostatic pressure is the opposite. It is going to mobilize the water from the blood vessel into the peripheral tissue. Okay, into the peripheral tissue. So it is a pressure that blood exert against the wall of the blood vessel. Okay, so how this pressure is created? When the heart is pumping, that is going to create a force. That is the source for hydrostatic pressure. Okay, it's like you assume a tap. You are going to open a tap which is attached to an plastic tube. That is the hose. Okay, so from the tap, the water will flow through this hose and it is going to come out through the other end, right? So when the water flows through this plastic pipe, it is going to exert pressure on the walls, right? So similarly, when the blood flows through the blood vessel, which is pumped by the heart, is going to exert pressure on the blood vessel. Okay, so walls of the blood vessel. Okay, that is going to help in mobilizing water from the blood into the peripheral tissue. Okay, so remember, in a particular blood vessel, if you have a high hydrostatic pressure, it will mobilize the water from the blood into the peripheral tissue. And in a particular blood vessel, if you have a high oncotic pressure, it will mobilize the water from the tissue into the blood vessel. Okay, so if you can able to remember this concept, you can able to understand that how nutrients are transported into the peripheral tissue, and how the waste products are, we are going to mobilize it from the peripheral tissue into the blood. Okay, So it is generated by heart pumping action and the volume of blood within the vessels. Okay, that is the volume of blood which is going to exert pressure over the blood vessel. So now we are going to use this concept to understand how the nutrition and the water is mobilized from the blood vessel, from the artery into the peripheral tissue, and how the waste product and the water is mobilized from the peripheral tissue into the vein. Okay. So to understand this concept, I'm going to that is we are going to consider this is an artery and this is a vein. Okay, so artery will divide into multiple small branch to form arteriole, and that will be divided to form capillaries. Okay, and again the capillary will combine to form venules, which will combine to form vein. Okay, so this is the artery, this is the vein. Okay, at the arterial side, at the arterial side the oncotic pressure is 25 mmHg. Okay, and hydrostatic pressure is 35 mmHg. Okay, so I told you whichever pressure is higher, that particular action will work. Okay, so here hydrostatic pressure is more than that of the oncotic pressure. Okay, that is hydrostatic pressure is 35 mmHg. Okay, so within the blood vessel, within the blood, the hydrostatic pressure is high. If the hydrostatic pressure is high, what will happen? The water will be mobilized from the blood vessel, that is from the blood into the peripheral tissue. Okay, so in the arterial end, that is still here, the water will be mobilized, water and the nutrition will be mobilized from the blood, that is blood within the artery, into the peripheral tissue and the interstitial tissue. Okay, now coming to the venous side, if you see the in the venous side, the oncotic pressure is 25 mmHg. Okay, and hydrostatic pressure is 15 mmHg. Okay, so in the venous side, the oncotic pressure is higher compared to that of the hydrostatic pressure. Okay, so now in the venous side, we know the oncotic pressure is higher. So what will happen if the oncotic pressure of the blood, that is within the blood vessel, is higher? The water will be mobilized from the peripheral tissue into the blood. Okay, since the oncotic pressure is higher, it is attracting the water. So water and the waste product from the peripheral tissue will be mobilized into the blood vessel, that is into the vein. Okay, so this is how the nutrition from the artery, that is nutrition and water from the artery, is mobilized into the peripheral tissue, and the waste product and the water is mobilized from the peripheral tissue into vein. So the same concept I written in words. Okay, so you can pause the video again and you can write it down. Okay, that is, I told you the oncotic pressure and hydrostatic pressure is the one which is going to decide whether the water and the nutrition has to be moved out, or the waste product and the water has to be moved into the blood vessel. Okay, that is in arterial side. In arterial side, the hydrostatic pressure is high, so the nutrition and the water will be moving from the blood vessel into the peripheral tissue. And in case of venous end, that is at the venous end of the capillary, the oncotic pressure will be higher, that is 25 mmHg. So the waste product and the water will be moving from the peripheral tissue into the vein. Okay, so next function of albumin is to involve in transport. Okay, that is, if you see, there are five major nutrition which we require, right? Carbohydrate, protein, lipid, vitamins and minerals. Out of this five, lipids and fat soluble vitamin, that is both are lipids. Okay, we cannot transport lipid as it is in blood, because blood is mainly made up of water. Okay, and you know all this five nutrition has to be taken in diet. Once you are taken in diet, it has to be absorbed and travel through blood to different part of your body. Okay, so this lipid cannot travel by itself in the blood, so it need a vehicle through which it can able to transport in the blood to different part of the body. Okay, that vehicle is nothing but protein. Okay, so you are going to transport lipid with the help of protein. Okay, and the major protein which is involved in the transport of lipid is albumin. Okay, so albumin is involved in the transport of lipid. Which are the lipid which is transported by albumin? That is free fatty acid, steroid hormone and bilirubin. Okay, apart from this, albumin will also transport minerals. Okay, and the major function, one of the major function of albumin is to transport lipids. Okay, apart from albumin, we also have apoprotein which is going to transport triglyceride and cholesterol. Okay, so albumin is mainly involved in transport of minerals and hydrophobic molecules. The next function of albumin is to involve in buffering action. it is a very good buffer. Okay, so why it is acting as a very good buffer? Because if you see, the number of histidine amino acid present in the albumin is high. That is, there are totally 16 histidine amino acid present in the albumin. Okay, and you know, in the previous class, that is from carbo amino acid chemistry, I have told you histidine has imidazole side chain. Histidine has imidazole side chain, and the pKa of imidazole is 6.1. 6.1, okay, which is close to that of physiological pH of blood, that is 7.35 to 7.45. Okay, I told you, if the pKa of a functional group of an amino acid or molecule, if it is close to that of physiological pH plus or minus 1, then it will act as a very good buffer. Okay, and you know, histidine has imidazole group in the side chain, and the imidazole group's pKa is 6.1, which is somewhat close to that of 7.35 to 7.45. Okay, so histidine is going to act as a very good buffer. Since albumin has 16 histidine in it, so albumin is also going to act as a very good buffer. Okay, so the third function of albumin is to act as a buffer. And the last function is nutritional function. Okay, albumin is called as the complete protein. So what is a complete protein? A protein is called as a complete protein. A particular protein is called as a complete protein if it has all the essential amino acid in it. Okay, I had taught you about the essential amino acid in classifications of amino acid, right? So if you have all this essential amino acid, that mat will fly all the same essential amino acid in a protein, you're going to call that protein as complete protein. Okay, so albumin is a complete protein which has all the essential amino acid in it. Okay, so what is the importance of knowing this? uh, if you are in need of a particular essential amino acid, I can able to break albumin to get that particular amino acid. Okay, for example, if I need valine, okay, I can able to break albumin and I can able to obtain that particular valine amino acid, which is an essential one. Okay, so if you, when you are in need of essential amino acid, albumin can it can be used as an source for that particular essential amino acid. Okay, so that is called as nutritional function. Okay, so what are the functions we have seen? We have seen the first function as the oncotic pressure, that is, albumin helps in mobilizing water from the peripheral tissue into the blood vessel. Second point, it is going to act as a transporter. Okay, it is involved in transport of minerals and free fatty acid and steroid hormones. Okay, so these are it is mainly involved in lipid transport. Okay, then buffering action. Why it is called as a good buffer? Because it has 16 histidine residue in it, and you know, say histidine is a very good buffer. And nutritional function, albumin is a complete protein, so it can be used as a source for production of an essential, that is, when you are in need of an essential amino acid. So that's all about the functions of albumin. Next, coming to the clinical significance. Okay, so to understand this first clinical significance, you should know superficially about the how RBC is catabolized, how hemoglobin is catabolized. Okay, I'm not going to explain in detail. You will be having a separate class about it. Okay, so today we are going to see superficially how RBC is getting broken down in our body. Okay, what is going to happen? Okay, so once the RBC completes its 120 days of cycle in our system, it will get broken down. Okay, when it is broken down, hemoglobin which is present within the RBC will be released. Okay, hemoglobin present within the RBC will be released. Okay, this hemoglobin will split to form heme and globulin. Okay, it will be split to form heme and globulin. Okay, this heme will undergo catabolism to form bilirubin. Okay, this bilirubin is called as unconjugated bilirubin. That is, the bilirubin produced from the heme catabolism is called as unconjugated bilirubin because it is not conjugated to any other substance. Okay, so this unconjugated bilirubin will be transported to liver. It will be transported to liver. Okay, it will be transported to liver. In liver, it will undergo conjugation to produce conjugated bilirubin. Okay, that is, I'm going to add UDP glucuronic acid to form a conjugated bilirubin. Okay, so what is the difference between conjugated and unconjugated bilirubin? First difference, it does not have UDP glucuronic acid, and this conjugated bilirubin has UDP glucuronic acid, and unconjugated bilirubin is insoluble in water and conjugated bilirubin is soluble in water. Okay, so this is the overview of RBC breakdown. Okay, so in which part of this breakdown process albumin is involved? That is for transporting unconjugated bilirubin, which is produced from heme catabolism, to liver. Okay, Once the unconjugated bilirubin is produced, it is water insoluble. Okay, so it has to be transported by some other molecule. That some other molecule is albumin. Okay, so albumin has two sites for the bilirubin to get attached. Okay, it has two sites where the bilirubin will get attached. So let's assume this is a bilirubin. Okay, and this albumin is going to transport this bilirubin, unconjugated bilirubin, to liver, and it is going to deliver this. After that, this unconjugated bilirubin will become conjugated bilirubin. Okay, so this is what happens normally. Okay, let's assume you are having a that is a child, and you are going to give aspirin or penicillin. Okay, this aspirin and penicillin will compete for this particular site. That is, it will try to displace this bilirubin, and that particular aspirin or um, penicillin will get attached to that particular place. So what has happened? We had removed that unconjugated bilirubin. Now this free unconjugated bilirubin concentration will be increased in the blood. Okay, and that will damage the brain. That is, in normal person, if you are going to give aspirin or penicillin for some condition, what will happen? This aspirin and penicillin will get attached to the place where the bilirubin is attached, and it will displace the bilirubin. So now the bilirubin is freed from albumin, so it will not reach the liver. Okay, it is not going to reach its destination. So it has become a free bilirubin, free unconjugated bilirubin. This free unconjugated bilirubin can able to pass through the blood-brain barrier, and it can enter the brain and it can damage the brain. Okay, this condition in newborn, which that is due to high bilirubin, which is going to damage the brain, is called as kernicterus. Okay, any condition which increases the bilirubin concentration in the blood, which is going to cause brain damage, is called as kernicterus. Okay, and one of the reason for kernicterus is increase in bilirubin concentration due to various reasons, and it can be enhanced when the patient takes aspirin or penicillin. So this is one of the clinical use of knowing albumin function, transport function. Okay. Second, albumin is used as a therapeutic in therapeutics. Okay, that is, I had told you, and albumin has oncotic pressure. What is an oncotic pressure? It is the pressure which is going to attract or mobilize water from the blood vessel, from the cell into the blood. Okay, from the cell into the blood. Okay, so now let's assume you have a patient whose blood volume is low, that is blood pressure is low. Okay, you want to immediately raise the water present within the blood vessel, that is in the blood. Okay, how to increase it? I am going to give lot of albumin intravenously. Okay, so what will happen to the blood level of albumin? Albumin blood level will be increased. When the blood level is increased, oncotic pressure will be increased. When oncotic pressure is increased, it will try to attract more amount of water from peripheral tissue. Okay, it will try to attract more amount of water from peripheral tissue. Okay, so more amount of water will be mobilized from the tissue into the blood vessel, so it is going to increase the blood volume. Okay, and to some extent it is going to normalize the blood pressure. Okay, so where we are going to use albumin in therapeutics? When the patient is having burns, hemorrhage, okay, hemorrhage, severe hemorrhage or burns. In burns, more amount of water and albumin will be lost from that burnt area. In case of hemorrhage, more amount of blood and as well as the water is lost. Okay, so this will result in hypovolemia, reduced volume in the blood. Okay, so to increase the volume, we are going to give more amount of albumin in intravenously. Okay, that is going to increase the oncotic pressure. Oncotic pressure is going to drag the water from the cell into cell and interstitial space into blood vessels. Okay, so this is the next clinical use, that is therapeutic use of albumin. So next, coming to the condition which will result in reduced albumin level in the blood and increased albumin level in the blood. How to remember this? It's very simple. I told you albumin is produced from liver, right? Albumin is produced from which organ? Liver. Okay, and albumin is going to circulate in the blood, and it will not get excreted in the kidney. Okay, normally it will not get excreted in the kidney. Okay, now if there is a liver damage, when there is a liver damage, first point, okay, when there is a liver damage, what will happen to the albumin production? It will be reduced. So that is one of the cause for hypoalbuminemia. Okay, second, when there is a renal damage, more amount of albumin will be lost in the urine. Okay, normally in urine there is the nephrons are going to filter the albumin. It will not allow the albumin to pass in the urine. Okay, it will be present only in the blood. Okay, it will not be excreted in the urine. But when there is a renal damage, albumin will be excreted in the urine. So more amount of albumin is lost in the urine. So blood level of albumin will be reduced. Okay, this is second point, that is renal damage. And third point, if the patient is going to consume less amount of protein, only with this protein, only with this amino acid present in the protein, which will be used for production of albumin. So the albumin production also will be reduced. Okay, and fourth cause is burns. So what are the causes? Cirrhosis of liver, that is liver damage; nephrotic syndrome, that is renal damage; and protein energy malnutrition. Okay, kwashiorkor and marasmus and burns. So these are the causes of hypoalbuminemia. Okay, in case of hyperalbuminemia, you can write down the causes dehydration. Okay, here the albumin concentration is not increased. Since the water is lost, it will show as if the albumin is increased. It's like you're going to take two cup of water. Okay, let's take 2 cup filled with water. Okay, in 1 cup I'm going to take only half the cup with water. In another cup I'm going to take full. That is, I'm going to fill the cup entirely with water. Okay, if I had 5 teaspoon of sugar in both the cup, which uh, cup will be having more sweeter water? The cup which has less amount of water, right? Here I added the equal concentration of sugar, but the water volume is reduced, so it is showing as if the sugar is high. Same concept here. Here the water is getting excreted either in the form of vomiting or diarrhea or fever, insensible fluid loss. Okay, because of that albumin, even though the exact concentration of albumin is present, since the water volume in the blood is reduced, it will show as if the albumin is increased. Okay, so the one of the common cause for hyperalbuminemia is dehydration, that is vomiting, diarrhea and fever. So that's all about albumin. Okay, so we had seen the important points related to albumin, what are the functions, the clinical significance. Next, coming to globulins. Now we are going to see in under each subclasses what are the proteins present in it and the importance points related to that. So we'll start with the alpha 1 globulin. Alpha 1 globulin mainly consists of 4 proteins, that is alpha 1 antitrypsin, retinol binding globulin, prothrombin and HDL. Okay, remember HDL is a lipoprotein, that is it is made up of lipid and protein. Okay, so these are the 4 important protein you should remember, which will come under alpha 1 globulin. Please pause the video and you can write it down. Okay, alpha 1 antitrypsin, retinol binding globulin and prothrombin and HDL. Okay, first we will start with alpha 1 antitrypsin. Alpha 1 antitrypsin. So when you write about globulin in your exam, okay, any globulin, okay, it can be alpha 1 globulin, alpha 2, beta, gamma globulin, okay, all these globulin proteins are, first point, glycoprotein. All of them are glycoprotein. Second, all of them are produced from liver. Okay, all of them are glycoprotein, all of them are produced from liver. But one exception is gamma globulin. Okay, so except gamma globulin, all other globulins, that is alpha 1, alpha 2, beta, these 3 globulin proteins, group of proteins, are glycoprotein and they are produced from liver. Okay, so whenever you write about any proteins which comes under globulin, that is alpha 1, alpha 2, beta, you can write down the first point is it is a glycoprotein. Okay, it is a glycoprotein and it is produced from liver. It is synthesized from liver. Okay, so what is the function of alpha 1 antitrypsin, which comes under alpha globulin? Alpha 1 antitrypsin, the function is, for example, now you take our current situation, that is November, December, you'll be having lot of LRI patient, URI patient. Okay, that is lung infection is very common in this cold climate. Okay, so when a bacteria or any organism which enters the lung, which is going to cause lung infection, will be destroyed by macrophage which is present in our tissues. Okay, which will be destroyed by macrophage which is present in our system. Okay, this macrophage, when it is trying to destroy this bacteria, what will happen? It will produce elastase. Okay, this elastase can damage our lung. Okay, this elastase, the elastase can damage our lung. This is neutralized by alpha 1 antitrypsin. Okay, alpha 1 antitrypsin is going to neutralize the elastase. Okay, so what is the main function of alpha 1 antitrypsin? It is going to protect our lung. Okay, normally when there is a bacterial infection of lung, macrophage is going to destroy this bacteria. During this process, it will produce elastase, which is this is going to damage our lung, which is prevented by alpha 1 antitrypsin. Okay, so when there is an alpha 1 antitrypsin deficiency, which organ is affected? Yes, it's lung, right? So the lung will be damaged. Okay, so that's all about alpha 1 antitrypsin. Next, coming to retinal binding protein. Now tell me, retinal binding protein is a what type of protein? It is a glycoprotein. Okay, and it is produced from liver. Okay, it is produced from liver. Okay, what is the function of retinal binding protein? It will be involved in transport of retinol, that is vitamin A, from liver to peripheral tissue. Okay, it is involved in transport vitamin A from liver to peripheral tissue. Okay, so that's all about retinal binding protein. Next, coming to prothrombin. So here also you are going to write up that is prothrombin is an glycoprotein and it is synthesized in liver. Okay, so what is the function of prothrombin? It is involved in clot formation. Okay, that is prothrombin. You will read in detail in physiology that prothrombin will get converted to form thrombin, and that thrombin is going to convert fibrinogen to fibrin, which is going to form mesh with on which the platelet will be trapped. Okay, which result in clot formation. Okay, so prothrombin is involved in clot formation. Okay, and there is something called as prothrombin time. Okay, it is a time which is required for clot formation. Okay, it is a time which is required for clot formation. So that's all about alpha 1 globulin. Okay, so we had seen about alpha 1 antitrypsin, which has lung protection, retinal binding protein, okay, which is involved in transport of vitamin A, and prothrombin, which is involved in clot formation. Next, coming to HDL. Okay, I told you this HDL is an lipoprotein because it is going to transport cholesterol from liver to peripheral tissue. Okay, sorry, from peripheral tissue to liver. Okay, it is going to transport cholesterol from peripheral tissue to liver. Okay, it has lot of apoprotein in it. That apoprotein will comes under alpha 1 globulin. Okay, it has lot of apoprotein in it. That is HDL has lipid, cholesterol and apoprotein in it. Okay, that apoprotein will come under alpha 1 globulin. Okay, so that's all about alpha 1 globulin. Next, coming to alpha 2 globulin. Okay, so these are the three important alpha 2 globulin you should know: ceruloplasmin, alpha 2 hepatoglobulin, and alpha 2 macroglobulin. Okay, ceruloplasmin, alpha 2 hepatoglobulin, alpha 2 macroglobulin. Like any other globulin, for ceruloplasmin also, we are going to start with the same 2 points. What are those 2 points? Ceruloplasmin is a glycoprotein. It is produced from liver. Okay. So what is the function of ceruloplasmin? It is involved in copper transport. You can remember C for copper. Okay. So it is involved in copper transport. Okay. So it is a copper binding protein involved in copper transport. Okay. So it is decreased in cirrhosis, nephrotic syndrome, and protein energy malnutrition, and it is increased in inflammation. When there is inflammation, ceruloplasmin will be increased. Okay, so this is the important point. Next, coming to alpha 2 hepatoglobulin. Okay, like the previous slide, we are going to write down it is a glycoprotein and it is synthesized by liver. Okay, so what is alpha 2 hepatoglobulin? When there is RBC rupture, when there is an excess amount of RBC rupture, more amount of hemoglobin will be released into the blood. Okay, when more amount of free hemoglobin is released into the blood, it can damage us. Okay, it can damage our tissue. Okay, so to prevent this, the haptoglobulin will combine with the free hemoglobin in the blood. Remember, free hemoglobin, not the one which is present within the RBC. Okay, the haptoglobin will combine with the free hemoglobin present in the blood, and it will form a complex that will be excreted. Okay, so when there is a hemolysis, there will be increase in free hemoglobin level, and this free hemoglobin can cause inflammation. It can damage our tissues. So excess free hemoglobin binds with haptoglobin and it will be cleared. Okay, so when it will be decreased, that is when there is increased intravascular hemolysis, for example sickle cell anemia, like this, any congenital disease or any drug induced intravascular hemolysis. Okay, when there is intravascular hemolysis, there will be increased free hemoglobin. So to neutralize it, more amount of haptoglobin will be used up. So because of that, haptoglobin levels will be reduced in intravascular hemolysis. Okay, it is an important point. In intravascular hemolysis, alpha 2 haptoglobulin levels will be reduced. Next, coming to alpha 2 macroglobulin. Okay, Like any other globulin, it is also a glycoprotein and it is produced in liver as well as in macrophage. Okay, so what is the function of alpha 2 macroglobulin? It is going to inhibit protease enzymes. Okay, so by inhibiting protease enzyme, it is involved in controlling infection. Okay, it is involved in controlling infection. Okay, so it is increased in nephrotic syndrome. It is increased in nephrotic syndrome. Okay, there is a reason for that. Okay, we'll speak about, I will explain about this in electrophoresis class. Okay, so in alpha 2 globulin, we have seen about ceruloplasmin, alpha 2 hepatoglobulin, alpha 2 macroglobulin. Okay, ceruloplasmin is involved in copper transport, alpha 2 hepatoglobulin is involved in excretion of free hemoglobin, and alpha 2 macroglobulin is involved in controlling infection. Okay, next coming to beta globulin. Okay, so these are the three important beta globulin you have to remember: transferrin, C-reactive protein, and hemopexin. Okay, transferrin, C-reactive protein, and hemopexin. Transferrin. So transferrin is also a glycoprotein and it is synthesized in liver. Okay, and the main function of transferrin is involved in transport of iron. Okay, it is going to transport iron from intestine to various part of our body, that is liver, spleen, bone marrow. Okay, so transferrin is involved in transport of iron, that is it will get saturated, it will get bound with iron and it is going to transport the iron to various part. Okay, so when there is iron deficiency anemia, the iron concentration will be low, so the transferrin saturation will be low. Okay, so transferrin saturation will be low in iron deficiency anemia. Okay, and transferrin level will be low in nephrotic syndrome because it is getting excreted in the urine. Okay, C-reactive protein. So C-reactive protein is also a glycoprotein and it is also produced in liver. Okay, C-reactive protein will be elevated in inflammation. Okay, it will be elevated in inflammation. Condition like myocardial infarction, rheumatoid arthritis, there will be severe inflammation. When there is severe inflammation, C-reactive protein will be elevated. So in condition like myocardial infarction and rheumatoid arthritis, C-reactive protein will be elevated. And the method which we use routinely to measure C-reactive protein can able to detect a higher values. Okay, but the lower end values, like we cannot able to detect 1 2, like a very low values, it will not be sensitive. For that we have different method and we are going to call it as HSCRP. Okay, high sensitive. HS stands for high sensitive to lower end. Okay, that is lower values. Okay, high sensitive C-reactive protein. Okay, so C-reactive protein and HSCRP both are same. There is nothing different in that. Okay, only thing is when you measure CRP, you'll get a very good value for higher end. Okay, you'll get an accurate value in the higher end. But when you use HSCRP method to measure CRP, you'll get a very good value in the lower side. Okay, lower reduction will be very good. Okay, so that's the difference. So that's all about C-reactive protein. C-reactive protein is very important. So we are seen about in beta globulin, we are seen about transferrin and C-reactive protein. Okay, hemopexin is similar to that of hepatoglobulin. That is, when RBC is broken down, free hemoglobin will be released. Okay, and here this hemoglobin will broken down to form heme and globulin. That free heme is also toxic to our system when it is present in excess. Okay, that will combine with hemopexin to form a complex which will be cleared from our body. Okay, so hemopexin is involved in clearing free heme. Okay, hepatoglobulin is involved in clearing free hemoglobin. Okay, so that's all about beta globulin. Next coming to gamma globulin. So we are seeing about albumin. In globulin we are seeing about alpha 1, alpha 2, beta. Next coming to gamma. Okay, so in gamma region we have only antibodies. So in gamma region, we have only immunoglobulins. So what are the immunoglobulins we have? That is immunoglobulin G, A, M, E, D. Okay. So how to remember this? Gamed. Okay. You can remember it as gamed. Okay. So these are the antibodies which is present in the gamma region. Okay. So remember, gamma globulin is produced by plasma cells. Okay. It's not produced by liver. Okay. It is produced by plasma cell. Okay. And they are not glycoprotein. They are proteins. Okay. They are proteins. Okay. And what are the immunoglobulins? You know, G, A, IgG, IgA, IgM, IgE, and IgD. Okay, so these are the immunoglobulins present in the gamma globulin. So we have seen about albumin globulins. Okay, fibrinogen is not that much important. So fibrinogen is involved in clot formation. Okay. So when I explain about different proteins in all this alpha 1, alpha 2, beta and gamma region, I had told you some of the proteins will be elevated in inflammation and some will be reduced in inflammation. Okay. So this proteins, that is the group of protein which is getting altered in during inflammation, is called as acute phase protein. Okay, acute phase protein. Okay, this is the important question. Acute phase protein. So what is an acute phase protein? They are class of protein, plasma protein, synthesized in the liver, whose plasma concentration increases or decreases in response to inflammation. So when a patient develops inflammation, either a protein can be increased or it can be reduced. Okay, so then all those protein which is getting altered due to inflammation is called as acute phase protein. Okay, if it is increased, you are going to call it as positive acute phase protein. If it is reduced following inflammation, that is immediately after inflammation, you are going to call it as negative acute phase protein. Okay, you should memorize all the names. So which are the positive acute phase protein? We have C-reactive protein, we have alpha-1 acid glycoprotein, we have ferritin, okay, a haptoglobulin, a ceruloplasmin, fibrinogen, alpha-1 antitrypsin, and complementary factor C3 and C4. Okay, so all this eight protein you have to memorize. It's very important. All of them are positive acute phase acute phase protein. So the negative acute phase proteins are albumin, prealbumin, retinol binding protein, transcortin and transferrin. Okay, transcortin is the protein which is involved in transport of cortisol. Okay, so all these proteins will come under negative acute phase protein. Okay, so you have to memorize all this protein. Okay, it can be asked as a 5-mark question. Okay, positive acute phase protein and negative acute phase protein. Okay, so what we had seen till now, we had seen what are the proteins which is present in the blood and what are their functions. Okay, and then we had seen about acute phase protein, positive and negative. So that's all about plasma proteins. Okay, thank you. So at the end of the slide, uh, I will add a link, that is over the video. I will add a link. You have to click that link. Okay, and it will take you to a Google form. You have to fill up the Google form and submit it. Today itself you have to do that. Okay, thank you.